role of bariatric surgery, the topic assigned in optimizing liver transplant tissue prior to whether pre, during, or post-transplant. And as we just heard, the best opportunity is doing before, but we'll see what the data are to support that. And most of the evidence-based medicine questions are not yet there, so we are going to base on whatever small studies have been published. I will try to optimize our understanding and application for future developing future therapeutic goals. Okay, no disclosures. So we have already gone through the obesity rates. Just wanted to point out that this landscape looks like what Dr. Sanyal doesn't like, the red states. However, 3 states are still blue, and those are the most 35% rate of obesity. This landscape had changed in 20 years. It used to be less than 20% for majority of the states, and now almost all states are crossing 25%, and 3 states are 35% or more. So obesity is going to be a huge problem, and more so in young population, that is children. And obesity-associated diseases specifically to this crowd are fatty liver disease, and fatty liver disease alone itself is increasing the burden of morbidity and mortality. So the rates of obesity along this paradigm we are seeing are shown for most parts over the world. Highest rate is in USA, and all other major countries in the developed part are showing increasing rates of obesity, including those in Asia, like Korea. So in parallel to the growing burden of obesity is the growing prevalence of fatty liver disease, as shown here. With increasing prevalence of obesity, there is significant increase in the prevalence of fatty liver disease that is shown here on the y-axis. And again, you can see that it is highest in United States. And if we were to look at the number of patients that are getting discharged, there's a clear increase in the patient population before and after. It's just a 20-year change that we are seeing. The NAFLD is almost 4-fold higher. So there's growing demand for liver transplant due to NASH-related cirrhosis. And this is seen now, what do the trends tell us? You can see that hepatitis C, the trend is slightly going down, and these are the data from the older days. And this is certainly going to have a remarkable shift down with the current therapies that are almost curative. And you can see here that the rates are significantly going up for NASH and cryptogenic cirrhosis. And recently, this was also shown by Izaz and their group that there's the data in retrospective manner analyzed from the UNOS. Listing for liver transplant in the United States is significantly 170% increase in those that are listed for non-alcoholic steatohepatitis. So the new waitlist registrants with NASH is tremendously increased from 800 to 27 or nearly to 2,200. And this is going to go up further. And this is another way to look at it. This was recently shown from about 15-year study data that we are seeing decreasing trends in hepatitis C-related transplant listing. And over here, there's increasing trend for NASH, and this is certainly going to go in this direction, and this is going to go down, which is hepatitis C. So here we are facing a tough task. 1, that obesities continue to go up. 2, that NASH prevalence is going up. And 3, the burden of NASH-related disease, which is obese NASH cirrhotics, that is going up. So we are here facing triple whammy: obesity, NAFLD, and obese and NASH. So the question that begs attention, because if we are targeting therapy here, where these cirrhotics who have decompensated and need to be transplanted, if we are going to intervene at this position, we are already way behind in the game. So as Dr. Kaplan pointed out, the sooner we recognize this problem, the better it is. However, the topic for today is to focus as to what can we offer or do to patients that are at this stage and are in need for transplant, and how we can optimize their candidacy for transplantation by doing surgical intervention such as bariatric surgery. So is obesity going to impact on the outcome? And this is a study that was duplicated or repeated based on the prior study from Dr. Nair's group. And this is based on the SRTR data over 20-year population. If you can see the graphs here, this is the number of years post-transplant, and this is the patient survival. And if you can see clearly, low BMI as well as high BMI, more than 40, are the two determinants of poor survival and certainly excess body weight is an increasing concern there too. And this is reminding you that there's no correction of ascites, so BMI may not be an accurate indicator here, but suffice to say that based on even the registry data, we are able to get a strong trend for survival with increased mortality in those that have BMI over 40. Now, what are the long-term outcomes in those patients that have NASH and NASH-related transplant? So this is again from the SRTR data showing from about 15 years, and the red one is NASH. So NASH and hepatitis C are the leading contributors leading to a proportion of patients that are not surviving after transplant. However, this is again an old data, way back from 2010, data 2010, and with the advent of newer direct-acting antiviral therapies, we are not going to see hepatitis C to be such a burden, and probably NASH is going to further increase this risk and risk of mortality. So here we are again seeing that NASH-related post-transplant survival is going to go down. So what's the impact of recurrent NASH on the outcomes? And this is again shown here, unadjusted post-liver transplant survival data from NASH versus the other groups, no NASH, non-HCV. When we exclude the hepatitis C, then this is a significant difference early on in the time period after liver transplant that the survival starts to decrease, which is significant on the log rank test when you exclude those that are non-HCV as well. And this is the data from Dr. Sanyal, and this showed that when patients are followed over time, this is time after OLT over 1,500 days, and this is the probability of being free of NASH or fatty liver disease. It is clear that within 5 years, every individual post-transplant developed fatty liver disease. And majority of those, almost 50% or more, developed NASH. So this clearly tells that there is a recurrence of disease. And so if you were to say whether this disease comes in those that are not that were transplanted for non-NASH causes, and this can be seen that de novo fatty liver disease is also a problem. And if you can see that the recurrence of the disease here and the de novo, those that did not have NASH before, even developed NASH in about 5 years. So the problem is real, and my subsequent following speaker has done excellent work, and he'll share some other data. But suffice to say here that these recurrent conditions are real issues and real problem. And the very fact that these patients required transplant, and as we do not know the natural history of recurrent NASH, which is being actively explored, this is going to be a big issue and how we can target and tailor our therapies to this. This is another example, post-liver transplant, aggressive recurrence, and this is usually in the setting that there are increased factors or promoting factors such as metabolic syndrome, in this case type 2 diabetics, and again possible concomitant cumulative steroid use. Now, what are our options in terms of surgical weight loss? There are two major strategies in bariatric surgery procedures. One is restrictive, and one is restrictive and malabsorptive. And these are listed under lap band or gastric sleeve, and then Roux-en-Y as well as the duodenal switch. But these are the two currently prevalent therapies that are practiced. Almost more than 95 to 98% surgeries are within these two groups, with increasing trend for gastric sleeve. What do they look like? So if you were to look at the normal anatomy, stomach going into small intestine, which is red here, and then you see the duodenum, jejunum, and ileum in these colors. And when you do the first part, which is Roux-en-Y or gastric bypass, you kind of create a small gastric pouch by surgical incision and stapling, and then try to separate this, bring the second part, which is jejunum, all the way and create an anastomosis, so gastrojejunal anastomosis, and bypassing a majority of the stomach. This pouch usually is about 30 to 50 ml in like content, then it starts to become full. So you are seeing that this is going to be restrictive, as well as you are bypassing a significant portion of small intestine, about like 60 to 100 centimeters, and then you are also causing malabsorptive nature. On this side, slide C shows the sleeve gastrectomy, which is again a tubular resection. The difference between the two is that you preserve the pylorus here. So you are able to eat the food transition is slower compared to here, which is rapid. So the side effects are more in terms of intolerance to like a certain type of food or rapid eating. However, the advantage of sleeve is also that we do not see a lot of nutrient deficiencies, as we are trying to preserve more of physiology. And then there is no discontinuity as bypassing the intestine. So we are in advantage that we do not have the like malabsorptive process, which long-term may benefit more than the type B, which is gastric bypass. So what surgical approaches one can adopt for patients with NASH? If those that have already been developed, like compensated cirrhosis, as we learned that our approach will first be in a stepwise lifestyle modification, and we do not, or we are over, like most centers, I would believe, underuse the medications for weight loss, and there could be a potential that these can be leveraged. However, these need to be very well studied for safety and efficacy. However, we also know that if we are able to achieve weight loss more than 10%, there is a significant benefit in regression in fibrosis as well as the metabolic complications. However, if we are unable to achieve those and these are considered transplant candidates, then a good option could be a laparoscopic sleeve gastrectomy or even Roux-en-Y, which I just showed why this may not be a preferred approach. So a sleeve gastrectomy could still be first surgery to choose. Those that have decompensated cirrhosis and obviously considered as transplant candidates, then weight loss in selected situations by non-invasive methods, as well as a potential for sleeve gastrectomy, which is considered either during or after transplant. Some centers, even there are small data that I'll show, that do suggest that this could be attempted even before transplant as well. So this is one of the first studies that show like bariatric surgery in cirrhosis. It is a retrospective data going back into the national inpatient survey sample over 20 years, or sorry, I think 10 years. Patients that were identified based on who went for bariatric surgery and were classified under three groups. One, that were non-cirrhotics. That was the majority, nearly 600 and nearly 700,000 patients. And then those were cirrhotics but compensated nearly 4,000 and decompensated 62. The diagnosis of ascites or varices required for the classifying them as decompensated cirrhosis. As can be seen here, the inpatient mortality was lowest in those that were non-cirrhotic, 0.3. Even the compensated cirrhotics were quite well, they quite tolerated the surgery very well, with mortality of 0.9% only. However, if you see that these patients, if they were decompensated and underwent a bariatric surgery procedure, then the mortality was substantially higher, 16.3%, and it was much higher in centers that were least experienced. The things that showed like length of stay is higher in those that were decompensated. So this is kind of like a very good data to try to see when patients are assessed in a retrospective manner, hospitalized, whether surgery is tolerable in those that have cirrhosis, gastric bypass surgery, and how do they compare between compensated versus decompensated. And this clearly shows that compensated cirrhotics are nearly comparable in terms of mortality risk when they are compared to non-cirrhotics. Laparoscopic Roux-en-Y in patients with compensated cirrhotics. This was another study that suggested that a large cohort of retrospective patients undergoing Roux-en-Y, they found to have cirrhosis. The downside was that it was only a visual inspection. They did not have histology to confirm. And they found that no death, no decompensation in a mean follow-up of 16 months. So they suggested that it is possible that one can choose weight loss approach or surgery like gastric bypass in child A using laparoscopic approaches. Then another study from the center showed that it's a prospective study of 14 patients, including those that had portal hypertension with varices and portal gastropathy, but low MELD score, and sleeve gastrectomy was done in 11 of those, and 3 had Roux-en-Y. No surgical complications was noted, and total body weight, 25% of total body weight was lost at 1 year, shown here in the red and the blue. And they concluded that bariatric surgery is safe, effective in compensated cirrhotics. Now, prior to transplant, this another study showed that of the 6 patients, again, remember, so small sample studies and small size, those that had grade 2 varices or uncontrolled encephalopathy or ascites, again, indicating decompensation, high BMI with stable hepatic synthetic function and metabolic syndrome improved, about 40% excess weight loss was achieved. However, you could see that there were some risks like bleeding. They were reoperated upon that. 2 developed ascites, 1 readmitted for encephalopathy, and mean stay was 4.2 days, and mean follow-up was 9 months. So sleeve gastrectomy prior to liver transplant, this is the weight loss that can be achieved, and this is possible. Now, weight loss after bariatric surgery in these 6 patients, a small study reflects that from pre-bariatric weight, there is a significant loss in each patient, which is blue to down here, blue to down here, blue to down here. So the context of achieving weight loss through surgery is possible in a pre-transplant time, or if it is timed in pre-transplant manner. Now, this is a very interesting and provocative trial, whether surgery could be timed during the time of liver transplant. So a combined liver transplant and gastric sleeve resection for patients with medically complicated obesity and end-stage liver disease was performed. And seen here, this is like how they have approached the 2 surgeries, and choosing that the gastric sleeve resection was combined with the liver transplant. It was not with any malabsorption, and the context was slower weight loss and technicality more possible to do while you are performing. In their data, they also compared 37 patients with non-invasive approach versus 7 combined with sleeve together with the liver transplant. And seen here clearly, those were the sicker patients with higher MELD score, and that is the reason OR time was not significantly different. And mean BMI was like remarkably higher in those that were operated together at the time of transplant. And the post-liver transplant diabetes was not existent in all the 7 patients, and BMI was remarkably down compared to the non-invasive approach patients. So since publication, the authors have further added 15 more patients, and total now of 22 with combined liver transplant with sleeve gastrectomy, and 4 with liver and kidney, and 1 was retransplanted, and 18 of those had NASH. So this is the data for all these patients, non-invasive weight loss that we talked about, and this was their BMI of 40. After transplant, at the transplant with non-invasive weight loss, they were able to achieve a significant weight drop from 40 to 33. And these are the patients, 37 patients shown here. There were 3 deaths while they were waiting for transplant with the non-invasive, and 3 patients required to be retransplanted after the transplant was achieved in the non-invasive category. 35% of these patients developed or had post-transplant diabetes, and 20% developed fatty liver based on ultrasound. In contrast, when you see all of those 7 patients with liver transplant and sleeve together, all alive with good allograft function, BMI was substantially lower, 28, no one on any insulin or antidiabetes, none on, no steatosis on protocol ultrasound up to 2 years, and there was minimal additional operative time. That was the only disadvantage with the time, but it did not result into any medical comorbidities. In fact, much improved metabolic parameters, both with weight loss, no diabetic medication, no steatosis. So by this study, they were able to describe that we are able to achieve simultaneous liver transplant with sleeve gastrectomy. Now, this is overall data for them. BMI at the time of transplant, 45, mean BMI at follow-up 31, and this is a long-term follow-up of 20 cases with sleeve gastrectomy and liver transplant, and this follow is up to 3 to 5 years follow-up, suggesting that only 3 patients had BMI more than 3 years. So surgically induced weight loss is able to achieve significant improvement post-transplant obesity as well as metabolic complications. Now, what is the case about like bariatric surgery post-liver transplant? And there are a couple of small studies that, like 9 patients, this was with gastric sleeve, and mean follow-up was short for 6 months, and BMI was high. So 3 patients required reoperation in the first 30 days. So post-transplant surgical weight loss approach may not be well tolerated. It's shown in this small study, so we have to be cautious. Similarly, another study that used open Roux-en-Y approach, only 7 patients, and again, the patient's death, 2 of those died, so which is very unsafe, and 1 had to be reversed. You can see significant weight loss from 38 BMI to 18.7. And so these 2 small studies, although small, but do tell us that liver transplant, after liver transplant surgical intervention may not be safe. So the key concept, liver transplant and sleeve gastrectomy, how at the Mayo Center they perform, they do the standardized approach of specific nutritional activity and weight loss goals. Weight distribution and ascites is important for the technical considerations as they show, and then they have a close follow-up for reflux, excess weight loss, and regain. Because that is one of the most important things, that if these patients undergo weight loss surgery, post-transplant, if they lose excess weight or develop multiple nutrition deficiencies, how will they be managed? And that has to be watched for. So issues after transplant in patients with a combined sleeve plus liver transplant, they typically have a protocol to treat for reflux disease, because that rate is increased post sleeve gastrectomy. Also monitor for excessive weight loss and do the nutritional counseling with supplements and micronutrient supplements. They also watch for early satiety and monitor for weight regain. So finally, bariatric surgery in decompensated cirrhosis. So before transplant, it is not considered as an option for patients with child B or C or high MELD score. And an option to consider at that time is either after transplant or possibly with concurrent transplant, which was shown by the Mayo data that this can be safely performed and could improve both post-transplant metabolic syndrome as well as post-transplant obesity risk. So finally, this is a thought to ponder, because these patients are on medications which are very important to prevent rejection or graft failure. So one of the big issues that we run into post-bariatric surgery is the predictable absorption of medications. And these are some of the big variables, like there is a certain change in gastric pH. There is obviously delayed or rapid gastric emptying depending on what the underlying cause was. And then there are intestinal changes as well as like first pass metabolism and enterohepatic circulation. These are all altered. And these are the mechanisms how they, by altering the solubility and dissolution as well as variety of factors based on emptying and intestinal changes, that could affect the predictable use of immunosuppression. So in conclusion, bariatric surgery is safe in compensated cirrhotics and could be performed and should be considered if they have failed other measures, including lifestyle as well as medication. It should best be avoided in those that manifest evidence of portal hypertension and is unsafe in decompensated cirrhotics. And if it is to be considered, a potential can be with liver transplant and sleeve gastrectomy. Sleeve gastrectomy with liver transplant is feasible and should further be evaluated with long-term data to really establish its efficacy and safety. Thank you for attention.